All right, guys, I am trying to be ahead of the game. They're predicting yucky weather on Thursday, so I am recording class today. Now, some of you had talked about the fact that you really benefit from seeing me talk. I don't quite get that, but I can play along, and so hopefully this will work for you. If we don't have, we will not have class on Thursday. If I'm going to spend 2 hours doing this, we will not have class on Thursday. However, I will be available between 1 and 3, if that's when you choose to watch the video. And you can call my cell phone, 749-6628, or text me, and I'll get back to you as soon as I can with an answer to your question. What I'd like to see happen, and I mean, I think it could work. If we don't have class on Thursday, I'm going to be at home. And you know, if you're watching the video and you have a class, hit pause and give me a call. That's perfectly okay. I might choose to call you back on my house phone because I have a good speaker system. So if I don't answer it right away, I'm looking at the phone number and I'm going to go over to my house phone. I'm processing that. But anyway, the subject of the day is respiratory failure. And good, I'm in good shape. Acute respiratory failure happens when you don't have good gas exchange. You have insufficient oxygen transferred to the blood. That produces hypoxemia. When we say hypoxemia, I mean oxygen in the blood. The inability of tissues to get enough oxygen is called hypoxia. And that hypoxia is much broader than hypoxemia. The problem with hypoxemia is that it can lead to hypoxia. Sometimes it doesn't, because the body may be able to compensate for hypoxemia by doing things like increasing heart rate, increasing blood pressure, vasodilating, constricting, letting oxygen molecules get off of the hemoglobins at a tissue level. There's some compensatory mechanisms that go into play to minimize the bad effects of hypoxemia on tissue hypoxia. Having said that, there still is a problem with that. The other part of gas exchange is hypercapnia or CO2 removal. When you don't have adequate CO2 removal, you end up with an increased amount of CO2 in the blood. No, that's not going to work so well. That is called hypercapnia. So remember the little gas exchange unit from physiology on this side. The pulmonary artery comes off of the right ventricle, behind the right ventricle, right atrium, then the body. So the body takes all of the used up blood into the right atrium, right ventricle, pulmonary artery, so this is deoxygenated blood. And then at a capillary level, and it is reasonable for you to picture that every alveolus has associated with it a capillary. And then that capillary alveolar unit interact together. And the exchange of gases occur. And then as you move to the pulmonary vein side, oxygen is moving into the pulmonary vein, and then that pulmonary vein goes to the left atrium, left ventricle, and out to the body. Acute respiratory failure is not a disease, it's a condition. Acute respiratory failure is generally a symptom of underlying pathology that's either going to involve lung tissue function, oxygen delivery, of which cardiac output is part of that oxygen delivery piece that you have to think about, and or metabolic state. So someone in acute respiratory failure might do okay. I didn't say this right. A person might do okay, namely their lung function is adequate to meet their daily needs, but then they develop sepsis and septic shock. Their metabolic rate goes up, and they go into respiratory failure because they can't meet the body's needs. Now, having said that, typically those things happen to people who already have some pre-existing conditions to where they just can't handle the additional load. There is not an exact or a universal definition for acute respiratory failure. It's usually the result of one or more diseases involving the lungs and or body systems. You can develop respiratory failure without having a problem in your lungs. Now, a common definition of respiratory failure is a PaO2 of less than 50 and a PCO2 of greater than 50. The process that ends in respiratory failure will begin with alveolar hypoventilation. Alveolar hypoventilation. Now, let's think about hypoventilation for a minute. When you think of somebody who is hypoventilating, I imagine the first thing that comes to mind is they're not breathing enough. And that could very well be true. Hypoventilation can refer to the big picture, what you see, respiratory rate. Okay? So someone who's breathing 4 times a minute, that would qualify as hypoventilation. But there is alveolar hypoventilation going on. And in this form, when we say hypoventilation alveolar, we're really talking about inadequate CO2 removal. And associated with that is often then inadequate oxygen getting in on the other side. But ventilation is more specific to CO2 removal. So a patient who's breathing 40 times a minute might be hypoventilating at a cellular level if 40 times a minute isn't enough to allow the CO2 to get out of the system. Alveolar hypoventilation compared to hypoventilation as a respiratory rate. That's what you need to think about there. In alveolar hypoventilation, it's either because the patient needs more oxygen than they're getting, maybe the airway is partially occluded and so gases can't get out, CO2 can't get out, or there's some disruption in the oxygen CO2, that membrane, the alveolar capillary membrane that's disrupted. These concepts will come up again. Acute respiratory failure can be classified as hypoxemic and hypercapnic. We'll look first at the hypercapnic one, just because it's short and sweet. Hypoxemic is a little bigger. As an overview, in hypoxemic respiratory failure, the primary problem is an inadequate transfer of oxygen between the alveolus and the capillary. And in hypercapnic respiratory failure, the primary problem is an inadequate CO2 removal. Both of these can be acute or chronic. In the hypercapnic respiratory failure, by definition, the PCO2 is above normal, so it's greater than 45 millimeters of mercury, and there's acidemia present with that. There is an imbalance between the ventilatory supply, the air in and out, okay, and a ventilatory demand, what is needed to keep the PCO2 and the pH normal. 3 concepts to keep in mind in this primary problem. Primary problem being inadequate CO2 removal. Most of the time, someone who has inadequate PCO2 removal, this is typically associated with substantial lung problems because CO2 diffuses across the alveolar capillary membrane pretty readily. So, there's usually an underlying problem. 3 concepts to keep in mind. The PaCO2 is higher than normal. The body can't compensate, and so the pH is at a level where more decrease can lead to a severe acid-base imbalance. So we talk about this alveolar capillary unit and the exchange of gas, and in hypercapnic respiratory failure there's an imbalance between the ventilatory supply and the ventilatory demand. And again, when we talk about ventilatory, we really are referring to the CO2 aspect. Normally, the ventilatory supply far exceeds the ventilatory demand. And what ventilatory supply is just the ability to move air in and out, okay? So when you're exercising and your muscles are metabolizing and you're using carbs and glucose, and the byproduct of that is CO2, and you're huffing and puffing and blowing off that CO2, that is your ventilatory supply. The air moving in and out to get rid of, okay, what you need to get rid of.